The classification of migraine that we have from the International Headache Society, the International Classification of Headache Disorders, is now in its 3rd edition. It dissects out a number of primary headache disorders, migraine without aura and migraine with aura. About 25% of patients have migraine with aura, and these patients have a neurologic disturbance lasting 5 to 60 minutes that typically happens before the pain starts, and 90% of it will be visual disturbance, jagged white lines that move across the visual field and grow in size, leaving an area behind the so-called scotoma. Now, 75% of patients don't have that. They have migraine without aura. The migraine with aura patient will typically go on to have the headache phase and the rest of the attack. In migraine without aura, patients will have one-sided headache. It will be throbbing or pounding. It will be moderate or severe. It will be made worse with movement, any two of those. Or they'll have nausea or vomiting, or photophobia and phonophobia, one of those. And this taken together are what you might describe as canonical migraine symptoms that differentiate the two. Now in ICHD-3, the International Classification of Headache Disorders, the 3rd edition, episodic and chronic migraine are dissected out. In fact, we don't use the term episodic migraine. It's come into the general lexicon, and when I use it, I'm really referring to migraine with or without aura on less than 15 days a month. And that's the umbrella term for that, you might say, would be episodic migraine. Chronic migraine is taken to occur when a patient has at least 15 days of headache in the previous 3 months, of which half of them, 8, should be clearly linked to migraine, either have typical symptoms or be treated with an acute migraine treatment. Now, if I was to contrast migraine in the classification system with cluster headache, which falls under the trigeminal autonomic cephalalgias, a cluster headache comes in 2 forms, and when we use episodic and chronic in cluster headache, we're actually talking about the length of the bout. And in the ICHD, the 3rd edition of the classification, if a patient needs a 3-month break to have episodic cluster headache, and previously what we'd done is we'd only used a month. So the episodic chronic in cluster headache refers to the breaks, you might say, whereas in migraine, episodic and chronic really refers to the number of days per month. The words are the same, but our definitions are very different. Now, a typical patient with cluster headache will have one-sided headache. It will be very severe, more severe than any other pain that they will describe, and it will occur in bouts, the so-called clusters, that will typically last 8 to 10 to 12 weeks, maybe once or twice a year, where they'll have anywhere between an attack every day to 8 attacks a day. And the attacks will usually last an hour or 2, be strictly one-sided, very severe pain, with one-sided what are called cranial autonomic symptoms. So eye watering, eye redness, nasal congestion or running, and ear feeling uncomfortable or full, eyelid drooping or swelling or flushing or sweating of the face. In general terms, the prognosis of migraine is excellent. If you live long enough, migraine almost invariably stops. We know that migraine in children is about, it's about 6% of children, and the ratio of males to females is 1 to 1. At puberty, the ratio of males to females picks up. So at the peak prevalence of migraine, which for females in North America is about the age of 41, there'll be 3 females for every male, and the 1-year prevalence for episodic migraine will be around 30%, about 27%. Now this tails off at menopause, and there's quite a drop in the female prevalence. And with time, the prevalence of the 1-year prevalence of migraine drops off. So in general terms, migraine tends to improve with time.